Our last session for the day. We are already running really behind schedule, and people have flights to catch. So we are going to definitely talk to you about some of these very important aspects that are listed in the last session. I request Dr. Ashish Duggal of RML Hospital to please come and moderate the session. And participants are, I don't know, Dr. Tripathi, Manjari Tripathi is here, Dr. Pravar Passi, Dr. Mukul Verma, Dr. Padma, Dr. Rohit Bhatia, and there's Dr. Monica Puri who is a Public Policy and Health Systems Government Affairs spokesperson. So please come and join us on the stage.
So good evening, we are at the fag end of the session, and nice to see you, Monica. We met after almost 15 years probably. She was a junior resident when I was a medical officer in RML, so now she is a policy head. Great to see you. And so this is a session where we will be talking beyond the medical therapy, what has already been discussed. Most of the things that we were supposed to discuss in this session have already been discussed. So we'll just touch upon some other things. So ma'am, Dr. Manjari, I would like to ask you about we have talked about mental health, we have talked about depression, we have talked about anxiety. In the morning, someone was asking about the cognitive aspects of multiple sclerosis. So you being a specialist in cognition also, so what do you think we should ask our patients about their cognitive problems? How do we address them? And how do we help them overcome these problems, especially the brain fog thing, where they have difficulties in understanding behavior things? So how do you approach that?
Absolutely. See, multiple sclerosis is not just affecting, the strength, the power, the sensation, but it also deeply affects the mood. There can be depression, there can be anxiety, there can be fear, there can be insomnia, there can be fatigue. Okay, so those are the softer aspects of the mental health. It can affect your memory, so you can have problem remembering things, particularly your working memory. Working memory means just immediately within few seconds to few minutes of what's happening and what you have to remember. The recent memory can get impacted because along with these episodes, every episode you have would cause some amount of neuronal loss, and that neuronal loss will lead to some amount of cortical atrophy, and this cortical atrophy will result in reduced brain volume, particularly in the memory bearing structures, and these would be your hippocampus and parts of your frontal lobes. So you can have the memory getting impacted, but believe me, if the mood is affected, if you're depressed, the memory can seem 10 times worse. So first is to take care of the mood, and if you're depressed, recognize it, report it, and then treat it. And if there's anxiety and fear, that also needs to be tackled. Sleep is very important for memory. So you have to tackle the insomnia, you have to tackle the sleep issues, so that at least you can retain things which are being told around or you're working around them. Then of course comes the genuine memory issues. So on that we can work. Now we haven't talked about vitamins in MS. There are studies which have shown conclusively that these two vitamins, one is vitamin D, and vitamin D is now essential to have vitamin D levels done in MS, because we have a study just this March and April published in JAMA Neurology, which is a big journal, which shows that when vitamin D levels were corrected and when vitamin D replacement was done, the recurrence of the attacks reduced, the relapses reduced. Now nobody talks about vitamin D and giving vitamin D. Similarly, we have another vitamin which works on memory, which is the vitamin B12. Now many of us in our country, we are vegan or vegetarian, and here you have vitamin B12 levels coming down, which can also impact memory. So apart from the MS itself causing cortical neuronal loss and atrophy, you have the vitamin deficiencies which play a huge role in the memory. Apart from that, the mood, the behavior, the psychiatric issues. So it's multi-dimensional. Then of course comes the fact that as spoken in the last, I always tell my MS patients that medicine is one part of your therapy. The other part of your therapy is engaging in meaningful activities which will help your brain. And because I'm also a cognitive specialist, this would mean interactive activities, interacting with the environment, interacting with games, whether it's Scrabble, whether it's Sudoku, whether it's puzzles, whether it's learning a new thing, whether it's learning a musical instrument, whether it's learning a new language. You know, so these are activities, or even a new skill, pottery, whatever it is, it helps you preserve your brain function. So that's something else which needs to be done. At the end of the day, if you really have genuine problems which are affecting your capability to remember, and this is interfering with your lifestyle, then you have to have memory hacks. You have to keep memory tools. The commonest tool which even I use, not having, I mean, all I have is migraine and hypertension, but then I have to note my things down. I will forget them, and I'm sure Pravar also forgets them at times. So we all keep these little tools with us. We have little diaries in our pockets where we note down what we have to read or what we have to do, the tasks, and then we use these. So don't be shy of using these, things Technology has made so much available to us. Then get frustrated over the memory loss. The more you get frustrated about the memory loss, the more it's likely to worsen.
Yeah, thank you. So this is a very important issue because many times these patients are complaining of memory loss. The family members just ignore it. They don't talk to the doctors. So this should be brought forward to the doctors, the physician we see. So Dr. Passi, another important aspect is the social stigma that is associated with multiple sclerosis, especially the young females who get diagnosed with MS, the prospects of marriage. So when a young female who is unmarried comes to you with a diagnosis, and you make a diagnosis of MS, and so how do you address these issues of marriage, employment? How will you address them, and what advice you will give to the patients who are here?
So I think the single bottleneck which I face is the time constraint. If I have time on my hands, which I usually don't, but if I have time on my hands and if I can spend 5 or 6 minutes with them, then I can explain it and convince them and the family members and the prospective in-laws that there is nothing that they need to worry about getting married, having a normal sexual life, having children, breastfeeding them. I might need to tweak a couple of things here and there, but having said that, the vast majority of things will be taken care of easily. Of course, as I said, the issue is time. So once time is not there, then I'm looking for counselors, or then I'm trying to pass the buck or something like that. But that's the kind of honest answer.
Probably the major problem is finding a suitable groom who understands the nuances of multiple sclerosis. Because most people have a misconception, probably outside the MS community, that this is a very disabling disease and ultimately the patient is just going to be bedridden, will require constant care. And probably, I will not completely say that they are unfounded misconceptions. They feel that probably they are entering into a mind which they may not be able to control over the next later part of the time. So, ma'am, suppose a patient comes with a prospective groom. So, how would you suggest, what will you tell them about the role of the...
So, fortunately, I've had many young women who've got married and have MS and have had children with no consequences which were adverse. My advice to all my patients is that life must go on. And, you can have MS before marriage, you can have MS after marriage, or you could have any disease which is 1,000 times worse than MS, like cancer. And we're seeing so much young cancer now. So really, it doesn't, I don't think anybody is there on this planet who doesn't have a physical ailment. And somehow, there's this whole thing attached that you have to be perfectly normal before marriage. So it doesn't hold true. Many people do not have overt disease, but they have covert disease. So before marriage, you won't even know the husband has a mental health issue till you get married, and there are all kind of impositions being put on by the husband to the wife. So how I counsel the couple who are intending to get married is, of course, there is a chronic disease with episodic manifestations, and we know that it's controlled with the medication, and the medication has to be taken. And we do have medicines which are available to be taken during pregnancy also, and we may have to stop certain medicines before pregnancy. I advise them that if you intend to get married, then there should be no two thoughts about it. We are there to help them through the course of their planning their life after marriage, whether it is pre-pregnancy, during pregnancy and post-pregnancy. And the good news for MS patients is that MS relapses actually don't happen in pregnancy. So pregnancy is kind of therapeutic for MS patients. And this is something which we've worked with our patients, and the results are pretty rewarding. You get informed about the baby showers, you get informed about the child becoming 2 years old, and the mom is on medicine. We do use injectables more often, particularly a particular one which can be safely used in pregnancy. So I think it's more of giving the fact that any disease can happen to anyone at any point of time, rather than focusing on that, okay, she has or he has MS before marriage.
That's a very, sir.
I also like to tell them, because when they're worried about problems after marriage, I tell them, anyway, all your problems are going to get multiplied after marriage. So MS is going to be probably just a small thing on the spectrum.
Yeah, exactly. That's very true.
So I do warn them, shadi koi laddu nahi hai. So the marriage itself can have its own side effects, and
it can be worse than MS.
MS is small compared to the marriage.
So another point is, as ma'am said, that pregnancy is sort of a therapeutic for MS, but at the same time, once the delivery has taken place, that's a time when there is a high risk for relapse. So we should make our patients understand that they need to get in touch with their physician, neurologist as soon as possible. So another, now I will move on to Dr. Puri. So, patient advocacy is a big topic now. So, what are the successful examples of patient-led advocacy in other diseases which we can apply to multiple sclerosis, especially considering the fact that we still have a large gap between the treatment which is available and which we are delivering to the patients, the cost of the treatments being very high. So what are your thoughts on that?
Thank you, sir. Maybe I'll just give you an example close to MS from prevalence perspective. Hemophilia. Hemophilia, of course, is considered as a rare disease, blood disorder, and we know that, a child, and especially boys, continues to bleed until death also sometimes. It's a Victorian disease because we know about hemophilia since then. In India, the prevalence of hemophilia is almost the same as prevalence of multiple sclerosis. But when it came to people knowing about it, there's hardly 28,000 patients known of hemophilia today. So when we started to advocate about what is the landscape for hemophilia treatment, it all started from awareness, really, and going to the states to even understand that every state in India, and health is a state subject, every state in India is so different when it comes to patients' awareness. Forget how the big hospitals are, how great the treatments are available, but for our district level hospitals, to doctors to even know that there are so many hemophilic patients in their own community was a starking revelation. From that point to making sure how these patients can get into the healthcare system very early, what kind of early screening tests is required, what kind of capability is required in terms of confirmation test, and making sure that these patients get into the system. I mean, since morning we must have talked about registry system, and thanks to Ms. Renika also, she mentioned that in their own MSSI, they have 3,000 patients registered when government is only talking about 1,000 patients. I mean, there are so many patients who are not even aware of their own conditions, forget they will ever get best of the treatments. So I think it all starts from first even letting people understand that they have a disease. It's not a one-off that they would bleed. It's not a one-off that they can just go take a pill or blood infusion and they'll be okay. So what has worked very well, that we initiated consensus meetings like the one we are having for MS today. We got patient groups like HFI, which is Hemophilia Foundation of India, like MSSI. We got MD NHMs. Just day before yesterday, we were in Bhopal, where we had the MD mission director of NHM being there herself. Every state has a government appointed nodal officer for diseases. And to have that SNO there, having district MOs there, having policy makers, having the pharma company there together to let's discuss. Because one of the most important aspects that we all need to realize, and I've been a, sir knows, I've been a student also, so done a clinic myself, then being with WHO, where making policies, working with corporate sectors. One thing that comes as a stark reality that we all need to admit and accept, that none of us will be able to solve it. As doctors, we will not be able to solve it. As government will not be able to do it alone. As private sector cannot bring innovations and wait that the innovations will, eventually be adopted. We all have to come together. And that is a learning we had from hemophilia. That is the learning we have for oncology. Indian Cancer Society. They have created their own app supported by many partners, which is all about awareness. And cancers are in thousands. And every cancer is different. Similarly, every MS patient could have a different trajectory altogether. These are some of the great examples which have worked in India. And this is something we would like to also see in the multiple sclerosis community also.
So thank you. So this is a very important point. We come together, institutes like AIIMS, where they are running a MS registry along with all 21 other institutes. The MSSI, the pharmaceutical industry in an ethical way can support all this, take it to the government, so that just like hemophilia, probably we can have state nodal officers for multiple sclerosis also probably in the near future, and that would be a welcome step. So next, another question for Dr. Monica. So what can you shed some light on the patient assistance programs that that are being provided by pharmaceutical companies, NGOs, and how can we build upon that so that the treatment gap in multiple sclerosis particularly reduces?
Let me also clarify, when we talk about patient assistance program, they are very individualistic in terms of how, in an ethical way, right, like you said, companies would like to support in their particular disease area. If I talk about other disease areas, some of the needs are the same, and which we have also realized, whether it is about every cancer patient needs to know what is going to be my journey now. You diagnose one day and you tell them, oh, you have lung cancer, and they just have no idea what is going to happen to me. The first thing that they know is I'm going to die soon, and all I need to do is sort out my family. I think making them understand that this is not the end of your life. There's a dark tunnel, but there's light at the end of the tunnel. To make sure that we are there to support them during their journey is something we do through psychosocial counseling also. Not just for the patient, but also for the caregiver. Because a lot of burden is, cancer does not hit a patient, it hits the entire family. To make them understand that how their life is going to change in the next few months is something we do through psychosocial counseling. We also do a lot of nutritional counseling, and which I believe are the common elements for multiple sclerosis also, because for a patient to really know what does it mean to be having a high protein diet. It's very easy to say, and now in the world of social media, there's so much of misinformation than information, that you need those experts to talk about those nutritional counseling. Then the third aspect is physiotherapy. Very, very important, and we've seen this in hemophilia, because these patients have joint bleeds and they become disabled forever. So they require that physiotherapy right from the beginning to understand what are the exercises they should do and they should not do, so that there's no more stress. So physiotherapy sessions. Then we also understand that patients may not be able to support the finances sometimes, because cancer could be leading to a lot of financial hardship. How can we have 0% kind of EMI program for them, so they can also be able to support their own finances. And sometimes if the patient is in a really bad state and we understand that he or she may not be able to support treatment, how best we can optimize for him so that patient can continue to make treatment. I think in the end, the essence is that patient needs support and they will not be able to do it by themselves. What best can we do to also make sure that we maintain the ecosystem that it is? And I would like to highlight, when we were talking about multiple sclerosis, I went back, I asked everyone, let's just understand from the MS patients, what are the specific needs that they may have. Sometimes the need is also, I want to get an MRI done, but I just don't know how to go to the hospital. Can you even help us with the taxi? I mean, these were the things we realized, that sometimes they want to get their diagnosis, but they just don't have a way to go to the hospital. So I think learning from the patients is also something that we are integrating now, because this disease area certainly has more challenges and there's a lot of scope. Ma'am talked about color therapy, sound therapy. Maybe these are the things that can also be included now. Thank you.
Thank you. So, Dr. Kameshwar Prasad sir is here. Sir, a few words from your side, please, regarding safety, advocacy in multiple sclerosis.
I'm sure everything has been already talked about, and I have hardly anything to add, but just to share with you that I think at the time of diagnosis, the most important thing is to counsel the patient and particularly take care of the anxiety which comes with the diagnosis of MS. Once the diagnosis has set in and they are comfortable, one thing which always comes up in the mind of the patient is the cost of treatment. And the second question which always comes up is there or can there be cure? So, cost of treatment, fortunately, is going down. I remember when teriflunomide came, it was one of the unaffordable treatment. Now it is easily affordable. So, similarly, other treatments, they have designed certain processes by which the cost can come down. So, we used to hear buy one, get one free in the stores, but now in medicine also we have seen buy one, get one free, and so on.
Buy 3, get 1 free.
Yes, so no one is buy one, get one free. So that kind of provision will help people to reduce the cost of treatment. I have always been talking about cure, possible cure of MS. And I don't see that day is very far, but I think science develops in that manner. I remember when I was doing MD medicine, then once we made a diagnosis of acute myeloid leukemia, that was the end of it. So there was no treatment available, and our professors used to say, give TLC, that is tender loving care. But a bold physician, Thompson, who started doing bone marrow transplantation and had results which won him Nobel Prize on one hand, but on the other hand, he established a treatment for this condition which was so informally fatal. But not only that, he started with, nobody wanted him to do this experiment, but he said, okay, I will do in cases where there is no other option or patients are desperate. So he started with that kind of patient and gradually ascended up to reach a level that, it's a very interesting long story, but it became first line treatment. So I think MS has already reached a stage where for highly active multiple sclerosis, there is a recommendation for hematopoietic stem cell transplantation, and it is coming from Government of India, Ministry of Health, Department of Health Research. We had a committee who have deliberated over all the evidence which is available, and you will find that for highly active multiple sclerosis, this is recommended treatment, hematopoietic stem cell transplantation. But I always remember a patient who came to me when we had just done first case of hematopoietic stem cell transplantation. And she says, she came walking perfectly fine and says, Doctor Sahab, hamara kar dijiye. No, you are perfectly fine, why should we do it? Well, then he, Doctor Sahab, I want it, do it for me. I said, no, we can't do like this. We have to take ethics committee approval, and you don't fit into those criteria. Go, what is your criteria? I said, criteria is that you should have highly active multiple sclerosis, you should have some degree of disability. So she says, Doctor Sahab, you don't know my family background. We, entire family except my father and myself, are alive, rest all died in an accident. In an accident. And I should also tell you that our family members donated, I don't know, perhaps more than 10 organs to All India Institute of Medical Sciences, and perhaps 10 lives have been saved because of that. You want me, I have only father now, you want me to get disabled? Then you will do some treatment, and my father is going to be old, and you think he can take care of me? I want this treatment when I am perfectly fine. So I said, no, I cannot do it, this is not possible. So she got it done in a private hospital, right? But she is so much etched in my memory that I keep in touch with her. So recently I called her, how are you doing? She says, I'm fine. You know, people used to call me that I'm suffering from MS. I'm fine. I'm not suffering from anything. So remember the wording. She says, I was suffering from MS. So she thinks she is cured. So I think time will come when, and it is not very far, when the process of hematopoietic stem cell transplantation, which is already having very few mortality, less than 1% at the present stage, will reach very soon at a level that people can say that yes, there is cure. With this hope, I think I want all of those who are present, whether you are care provider or you are suffering from MS, go with a great hope. Thank you very much.
Thank you, sir. And this is, I believe, the hope of the entire MS community. All the neurologists, the patients, the MSSI, the government, the pharma, no, probably not the pharma, but this is what all we hope, that there is a cure for MS, and probably hematopoietic stem cell transplantation is the panacea here, which can help all the patients who can afford to lead a good life. Even without that, the medicines that are currently available, if they are given to all those who need them, then even then there is a significant impact on the quality of life. So I would just like to end this session with a comment from everyone. So how do you see the MS community 5 years from now? What is your dream that we should achieve?
So I think 5 years from now, the community will definitely be bigger and the voice will be more unified. It will have a lot more digital presence, and there will be a lot of inputs from many other people, just other than patients. There will be industry involved, there will be the government involved, there will be healthcare providers which will be involved, there will be social workers and philanthropic organizations will be known. So it'll be like it'll be a cornucopia of things, but I think the voice will be much more heard in the years to come than as it is now.
Yeah. Especially with you coming down from Indore, especially for this conference, giving your views, this all just helps the community to project it in a good way.
No, I came just to be away from my wife. Meeting is secondary.
He has a very lovely and sweet wife. I don't know why I keep saying that. So I feel that, 5 years down the line, we'll definitely have fewer helpless patients or no helpless patients. I mean, don't ever feel helpless, because the movement is on and there are better drugs. We will have better holistic management for MS. Believe me, in my clinic, the first thing is I tell them, please allay your fears, remove what you've read from your mind. This is the medicine you have to take, but along with this, you will do yoga, you will do physical activity, you will keep positive, and you will involve yourself in non-stressful activities. And it goes a long way. So we'll see more holistic management. Believe me, we have studies ongoing now for MS and alternative, level 1 evidence studies, randomized studies are ongoing with us also, where we are doing blinding and all yoga, physical activity, diet. So this is a lifestyle kind of management. And of course, you have the vitamin D thrown in, vitamin B12. Vitamin D is effective, as I told you. So 5 years down the line, we'll be much better off. The only thing is that as far as patients goes, it's the MSSI which has put all of you together, and this effort should not go waste. The patient voice is a very important voice for advocacy with government and government policy. So I think that's the note I'll end with.
And I can assure you, she didn't come to be away from her husband. Like 5 years down the line, I would like to see MSSI having a greater voice in deciding the course of action as regards research, as regards treatment, as regards rehabilitation. And I think I have been saying this for a long time, that the research agenda should be set by patients, not by the researcher community who have their own priorities. What is the priority that patients can determine? Patients can raise their voice and say, this is what the priority is. And I wish that, and I'm sure in 5 years down the line, it will be stronger and it will be more, I think, listened to by the policymakers as well as researchers. I also know that there will be much more or many more options available for treatment, and cost will be certainly affordable, because the way things are going, I have no doubt in my mind that 5 years down the line, cost issue will be probably very much a low priority. But I want MSSI to grow to an extent, and I hope they will grow in 5 years, that they can decide what are the priorities for research, how the treatment and cost of treatment should be managed. And we are all with you. So whether it is society in India, but I am also a member of Multiple Sclerosis Federation, particularly the research board, where I keep raising my voice, which is on your behalf. So I think hopefully things will be such that it will be much better, both ecosystem of treatment as well as your own level of comfort. That's what I think will happen in 5 years. Thank you.
So the advantage of being last is that I can summarize for all of you. 5 years is actually a very good goalpost, because 2030 is also going to be the year where all countries have signed up to deliver on the Sustainable Development Goal of Universal Health Coverage, which it says Goal 3.8, leaving no one behind. So what we want, that every voice of MS patient matters, and that is why there should be a public-led, patient-led, concerted public voice, because government has to be on that table to have a concerted MS network. This is just the beginning, but if we can have a concerted MS network, patient-led, public-supported, and everyone comes in, then I'm sure by 2030, when we say leaving no one behind, all MS patients will be counted and being taken care of. Thank you.
Thank you, and I believe the registries, the MSSI, one thing which I feel should be taken up, the invisible symptoms, it was being talked about earlier. Some patients do not have any locomotor disability, they don't get that benchmark disability, it is not there in the disability gazette. So fatigue, cognition, this all is not checked and is not accounted for when the disability is being given. I would really commend Dr. Manjari. She has done a lot for epilepsy. Now patients with epilepsy are being given disability certificate depending upon the disability. Earlier it was very difficult for a patient with just epilepsy to get a disability certificate. Now it's become much easier. Probably something like this can be done in multiple sclerosis also, where these invisible symptoms are accounted for.
So can I intervene here?
Sure, ma'am.
So if you look at the disabilities provisions, it says chronic neurological disorders such as, and there are 3 or 4 listed there. That does not exclude MS. So please understand that you have to go to the clinician, the neurologist, and they will assess your physical disability based on your neurological problems. Then they will send you to a neuropsychologist, which is exactly what we do at AIIMS, who does your cognitive evaluation. And then we go for the locomotor disability, which will be done by the PMR, or it also gets done by our resident. Then there is a cumulative score, and that gets added up and then divided, and then you get a percentage disability. So people with multiple sclerosis are getting disability assessment and certification. But if you do not have any locomotor, you just have had one episode of diplopia and that's recovered, and you are fully ambulatory and your cognition is intact, then I think you will not fit into the category of that percentage which will make you disabled.
Yes,
and you should not also. You should feel happy that you are not disabled. But then there is a process.
But the problem is, there were a few patients, they had difficulty in writing. And they don't get into that benchmark of 40%. They don't get those benefits. They have some cognitive issues. Even with those, fatigue is there, which is not measurable. There are several other depression and anxiety. All this makes the quality of life very miserable. But we are not giving them advantage for that. So probably
the grey zones need to be factored.
Yeah, that's what I was saying.
I know it's not the time to raise any question, ma'am, but just one submission. The RPWD Act section 2R and 2S, they define persons with disabilities and persons with benchmark disabilities. So the RPWD Act section 2R and 2S, they define the terms persons with disabilities and persons with benchmark disabilities. Now for all other types of disabilities, we are okay with issuing a certificate with 25-30% disability also. Why not in MS? Even if it is not fitting into 40% benchmark disability, why not in MS we go down 40%?
I think that will be driven by research. So if you have patient data of several patients and you have categorized it with their activities of daily living, their quality of life, and then you have seen that, even though they don't have a physical so much, but they have, as he said, mood, and they have fatigue, and they have, cognitive issues, then that needs to be scored and factored in, and that scoring needs to be, somehow validated. So I think it's a research-driven process. It cannot be done hypothetically. It should be done.
Only thing, ma'am, is in the whole of the Act 102 sections, there are only 7 or 8 sections which are actually pertaining to benchmark disability. Those are mostly in employment, and one is section 91 where it talks about misuse of any benefit meant for persons with benchmark disability. That's only 8 sections which talks about benchmark disability. Everything else, even in employment, in transfer matters, Supreme Court has held that it is not restricted to benchmark disability, it is available to any types of disability. DOPT issued a circular also to that extent, that it is available to even 30% disability. So that's my submission. Even in MS, we can try and work together.
So
and,
I think that's a job for the MSSI on a finishing note.
Yeah, thank you. Thank you.
So thank you everyone for the patient listening, and thanks everyone for staying back so long. And now I hand over the mic to Ashish.